yeah, I don't actually know what a cold open is, Preston. I just am like, what do you mean by that?
Oh,
Do you wanna tell me what you mean by that?
yeah. So, like, a cold open is, like, whenever you watch a show like The Office or something,
Mhm.
and they start out with just a skit without this whole intro of, like, "Hi, welcome to The Office. Let's run the office television thing." It's just like, "Oh, look, here's, Jim putting Dwight's stapler in Jello."
Oh,
And then
okay.
it's like a tight 30-second scene, and then they go into the intro. That's what a cold open is, because it's like, you open
So
cold
so I don't we're cold
without all
plunging right into
the
this
bells and
episode.
whistles and everything. Yeah, exactly. So us doing a cold open could just be like, we bring the audience in mid-conversation, like we're in the middle of a bit or
Oh,
something.
okay.
Yeah,
Okay. So
but
it's not the ice. Well, we would have to be funny. I feel I'm rusty at being funny
we could
right
be a little
now.
bit icy to each other.
We could
So,
have a fight.
actually, I had a good joke earlier that I think really got me out of my, like, dry spell of not being funny. So, we were in supervision, and we had this guy sitting with us, and he said that Freud was asked, "What are the things that lead to good mental health?" He was like, "If you were to put a paper together, what makes good mental health? Can you write it out?" And Freud's like, "I don't need a paper. I just need 2 words." And he spoke German. So the 2 words were Liebe and Arbeit, which if you're familiar, it's Liebe means love and Arbeit is work. And we were talking about someone's, patient who wasn't accepting help, and I was like, "Oh, that she's Arbeiten the hand that's leaving her." And then and I got my preceptor to laugh pretty hard. So I was like, "Alright, I'll see you guys next week."
I'm just, like, picturing you saying it, and you're just, like, leaning in, like, "Hey, guy." You're like, "I've been working on this one. Stop it. Stop it." Um,
Yeah, and it was the we had a guest supervisor. It was his first time with us today. He's been with the department for, like, 30 years, and I was like
and you were like, "Nailed
I
it."
was like, "Welcome to Preston's Continuity Clinic mornings."
Did he laugh?
He laughed, but it was like one of those, like, I'm laughing because I see other people laughing. I'm, like, empathetically smiling along, but I don't think it hit him the same way it hit the
He's
rest
like,
of the crowd.
"Psychoanalytically, I'm laughing."
Yeah, it's okay. So,
Uh,
today, we are talking about alcohol use disorder.
and if we didn't have a copyright infringement, I wish we could put that the teen drinking is or whatever. I got a fake ID though
Teen
from
drinking is very bad.
and then
"Hey, I
just
got a fake
bam.
ID though."
We are
So,
not
like,
talking about
everybody
teen
in the
drinking
club getting
today.
tipsy.
Yeah.
Yeah, something like that. So,
Everybody in the club is worried because of the Surgeon
of
General thing
in the
that
amount of alcohol that you've been consuming.
well,
Not you specifically, but, like,
me, you, royal you, we
yeah, as the country,
as
we've been
yes.
drinking a lot.
Are you familiar with the Surgeon General's thing that came out?
No, no. What came out?
So before, so this is I think back in December, the Surgeon General had announced like a recommendation, so not necessarily like a publication, but like a
Mhm.
recommendation that there should have to be like carcinogen warning labels on alcohol. And that is why everyone's suddenly been having the conversation around like, wait, alcohol is poison at any dose? And why people have been having a new convo. Although it is not the Surgeon General, but it's interesting that that happened in December right before dry January. Is big
Mm,
mocktail behind it? I don't know.
maybe I think it's just RFK Jr.
I feel like, I'm just so aware of interrupting you now. Like, don't interrupt him
Oh,
again.
yeah, so if you're listening, we got someone wrote in,
Don't
they
at
were like,
them.
"Margaret interrupts too much." And then someone else was like, "I'd like to hear Margaret talk more." And then someone was like, "Margaret goes, 'Mhm,' too much when she's listening." So Margaret's just been kinda she's punching the wall about, like, how to interact now.
I'm just well, and we had this conversation where you were like, early on this is like by episode 4 or 5 where you were like, "You need to feel more comfortable interrupting me because
Yeah, and then
I" this
I
is
gave her
behind the
feedback too.
scenes.
I was like
Well, this is before the other feedback, and you were like this is behind the curtain for our listeners, like, you were like, "You need to feel comfortable interrupting me because sometimes I'll just continue talking, and I want you to feel empowered to do that so that you we have more of a back and forth," and I was like, "I don't really want to do that, um, but I'll try, and that's a good point." And now I'm even more like, he I will just silently nod in the back. We'll make my screen black and white, and
Mhm,
I'll just be in a like, a silent movie while you're in the color vision.
yeah. Well, and so conversation is hard. It's not fair for me to just be on a runaway train and then be like, "Oh, I'm not responsible for including Margaret in the conversation. She should just interrupt me." So, I can also improve there and kind of reel you in more. But here's me saying I've I have toes. I'm using my fingers, but these are toes.
No.
I want you to step on them and cut me off in conversation when you have something worthwhile to say. And speaking of things worthwhile to say, we have a couple fun topics on alcohol use disorder. So when we come back from this quick break, we're going to be going over discerning between this kind of normal or adaptive alcohol use
Mhm.
and find out on the spectrum where it becomes a disorder. And then we're going to talk about some of the neuroscience of alcohol, specifically the neurotransmitters and how it affects our addictive pathways. And then Margaret is going to lead us on medications and therapy approaches.
Yeah. We got feedback that everyone's comments and reviews have been really helpful, and so one of them was, besides me interrupting you, which I shall continue to do despite feedback, was wanting kind of more clinical discussions between us, and so in that part, we'll talk about medications, but also hopefully maybe try and talk about some cases or situations that come up that are a little bit more nuanced, that can give people something to chew on. So we'll be right back.
So when we look at the culture of drinking in the US, especially in young adults in medicine, Margaret, how do you think about alcohol as a part of our culture?
I think there are so many stories about alcohol that any of us has and picks up and probably uses different ones at different points in our lives. Um, I think when you're like 18 to 22, there's an alcohol story of like what's normal, which sometimes we equate normal and good. I would say it's more normative, as in like it's common.
Mm,
Um, I actually, fun fact, did not drink till I was 21 because I have an Irish Catholic background, and I'd heard enough stories that I was like, and I was scared of the law. So I was like, "I'm gonna wait." Um, so I think I had a story always that, like, alcohol was this big bad thing, and I was a square, probably in a lot of ways. So
mhm,
there's a cult so I give that as an example of, like, there's cultural stories we have. Some people have really positive relationships with alcohol. They grow up around, like, having a glass of wine with dinner with their family.
mhm,
Um,
but for you, it was forbidden fruit.
yeah, I think it was scary, and then once I got, though, into my, like, past 21, then drinking was something that was, like, fun, and we would go out to bars and dance, and it wasn't, it was something where it was, like, I would have a couple drinks, but I had done the awkward thing of, in college, going out to things where you're, like, in a dorm room with 20 other people, and everyone else is drunk besides you, and you're holding a Sprite, and
Mhm,
so I felt like that forced me to deal with my own social anxiety and, like, learn to be that. So for me, it was scary, and then it was fine, and now it's like, you mentioned in healthcare, and now there's this part of, like, what does alcohol mean for me as I'm 30 now? Like, do I wanna interact with it the same now as I did in my, like, mid-20s? And then also, how do I think about it for patients? And what does h I do think there's a healthcare component of, like, people working in high stress jobs and just seeing a lot of things, and, like, coming home after a long day at the hospital and
mhm.
having a drink. But so those are all my stories and just also some categories of stories people can have. What about you?
Yeah, I think I've always seen alcohol as a social vehicle. Like,
Mm,
I think it's just common in human society. The substances with which we use to cope correlate to our status or the type of character that we're trying to portray. I
yeah.
remember like the cool kids who didn't care would smoke cigarettes or they would go I remember they would go smoke weed, but they wouldn't have like pipes, so they would do it out of like an apple. Like they would
Hmm.
bore the apple and then like stuff a bunch of weed and then smoke out of it. And so like I would kind of hang around these kids and try to act cool, like, oh, I I don't care about these, like, rigid normative rules, like, don't
Mm.
do drugs, so, like, for me, alcohol was like a vehicle to become cool, like, the fact that I
Oh, okay.
was able to have these stories about going out to a party and drinking what was, like, currency for me.
Yeah.
It was like social stature, so, I think for a long time, I saw alcohol as just, like, a part of this kind of life that I had idealized, and
Mhm.
then I also had the stories of it being bad, not in a way that it's like a sin or something that should be forbidden, but that, like, people can get sick from it. So I had an uncle who struggled with alcoholism,
Mhm.
and it was the kinda thing, like, my mom would bring it up, like, in the car, like, "I want you know, that's your uncle, like, he drank way too much, then he went to the army, and then he got kicked out for snorting glue and drinking too much cough syrup," and I was like, "Whoa, that's a lot.
Mhm.
Okay, mom," and then she'd be like, "Anyway, so don't drink too much because you have alcoholism that runs in your family." And then that was, like, the end of the conversation, so I was kinda like, "Okay, here's this thing that's
That
like."
is the story that was my child. That was yes,
Yeah,
same. That was the story.
I'm like, "It's sexy, it's fun, it's cool," and also, I have family members that have suffered from it, so, like, it was
Mhm.
hard to reconcile those 2 things. And then I remember for a while, people kinda were pushing this narrative that, like, "Oh, as long as you do, like, a glass of red wine at night in moderation, it's cool and it's actually good for you because of antioxidants."
Yeah.
So I think you had something you were gonna say to that.
Yeah, so that was kind of I feel like that research was the most prevalent when people were really kind of big on the blue zone idea or the
What's
idea
the
that
blue zone idea?
the blue zone idea is research that was done originally, in the field of, like, gerontology, and it was basically there was these populations of people that it looked like certain areas in the world had more like, a significantly higher number of, like, over 100-year-olds or
Mhm,
centenarians, over 100-year-olds. And so in the gerontology world, they were basically going to look at it and, Maintenance Phase, the podcast, did a great episode on the, like, nuance of this. Basically, they went to look to see if, like, why are these people so old? What's going on here? Are they really this old, or is this just, like, a misunderstanding? Da, 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 da.
mhm,
I won't get into that, but one of the things was, like, red wine, Mediterranean, like, these people are healthy, and they have a glass of wine with dinner, da, 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 and then there was research from, like, a few studies on in cardiology on the kind of heart health possible benefits from very, like, mild to moderate up to, like, a glass a day of red wine in particular.
like, grapes have antioxidants and grapes are in wine, so some of those antioxidants, like, make it through.
I think it like, there was some better theory than that. I can't speak to the direct theory
Mhm,
towards it, but, like, I think there was some "This sounds true-ish," or "This, like, is correlative data."
I see.
Um, but I think what we know now is one of the things that they hadn't accounted for in that data, a I was listening to another like, lecture basically on this a couple weeks ago. One of the things they didn't account for in the data was that basically there was a graph that it looked like people who didn't drink at all had slightly more like, morbidity and mortality risk than people who drank a little bit, and then the curve went back up for mortality and morbidity risk as you, like, go into more and more drinking, right? And there's, like, a dose response there. But now there may be a thought that that may just both be true, and there may be a correlation, not a causation, as, like,
Mhm,
maybe people who don't drink at all have a history of drinking differently and they had to stop for a certain reason. Maybe
mhm.
they don't drink at all because there's other things going on mental health, physical health wise that preclude it, rather than the glass of wine made their health benefits.
So it's almost that moderate drinking is a confounder for a healthy lifestyle,
I think that's
and
where we
that
are now.
that the
Yeah.
healthy lifestyle was the true predictor.
Hmm.
That's kinda how I heard it too,
Yeah.
was that a glass of red wine at dinner once a week is correlated with being, like, a rich snob, and being a rich snob is correlated with living longer. And I'm being, like, a little tongue in cheek here, but I if you can find a way to bring it back to socioeconomic status, that's almost like your track home to, like, "Okay, this is probably why," as your confounder. So I live in San Antonio, and
Hmm.
our town is broken up by neighborhoods,
Hmm.
and, like, my first day of residency, we looked at, like, average price per home mapped onto neighborhoods, and then also, like, life expectancy, kidney disease, rates of obesity, and
Yeah.
all of the places you'd expect, like, light up exactly the same, and you could probably do a similar thing with, like,
They showed
moderate
us that.
alcohol
Yeah, and
consumption
they
and
showed us
and
that in
similar
St.
things.
Louis too, and it was, like, called the Delmar Divide there, where it's, like, a couple decades and all these yeah.
Yeah,
Yeah.
no, it's tough here, so we have this place called Almost Park,
Mhm.
and it's actually its own municipality because back in the
Mm.
'50s, they're like, "Oh, if we make ourselves our own city, then all of our own taxes can go into our own police force, and also we can write special laws like brown people can't live here.
Mhm.
And then those laws didn't get repealed till, like, way later than they should,
Yeah.
you know?
Yeah.
And then now we look at it and we're like, "Oh, okay. These all correlate directly with, like, a lot of
Right.
outcomes, especially, like, life expectancy and morbidity, mortality."
Right. Which I feel like this concept is just as important as the thing we're talking about today, but, like, in the current information landscape right now, online, in the last 5 years, but especially now with, like takes 5 seconds for someone to, like, throw a claim out there, and it takes, like, 5 hours for an expert to explain why that's a misinterpretation of data, and
Mhm.
so I feel like us touching on this now and as we go forward on, like, how do we know what we know when we're talking about these studies is super important for our listeners, whether they're in healthcare or are a consumer of information about their own health, and I feel like correlation mistakes are so common, and it's
Yeah.
part of why this alcohol thing has been confusing for people.
And they're packaged as clickbait really well. And,
Yeah,
like, we need to acknowledge that at their core, these studies are looking at groups of old people who lived long and saying maybe something about their habits is the reason why they lived longer.
right, right,
And for a lot of it, it could be a bad habit. So it's like they lived long despite smoking every day. Not
right.
that smoking every day is what made them healthy. Because everyone can think of that one grandma who lived to 110
Mhm,
smoking a pack a day, but we all pretty well understand that it's not good for you.
right.
And it's easy to make those misinterpretations with
Yeah,
alcohol. So I guess the next point that I wanted to get to, which is we're looking at moderate drinking, no drinking, and excessive or pathologic drinking. How do we draw the line between that? And I
mm,
know we have a lot of different metrics that we use to measure misuse of alcohol.
mhm,
How do you kind of measure it in your patients or in people that you see?
yeah. Thinking about how much is someone averaging each day, and then thinking about binge sort of episodes, for functioning purposes as well as, like, physiologic health and dependence. So if someone's drinking, like, every day, one of the things I found helpful is, like, the term, like, harmful alcohol use as, like, kind of the spectrum someone can be on.
Mm,
And so if some I think about, like, if they're drinking every day, how much they're drinking every day, if they've ever had, like, withdrawal or detox, all those things, dependence, and then there's multiple types of screens and then, like, evaluations you can use, either CAGE or DAST or audit, which are the
hmm.
names for those, but the 3 Cs I feel like in my mind is always helpful of the, like, craving, consequences, and maybe it's not that helpful, so I can't think of the 3rd one. Um,
Can't stop.
is that it?
No, I just made
Control.
that
Oh,
up.
it's control, so it's close,
Oh,
yeah.
craving consequences and control. Okay, that's good. I haven't heard that.
Yeah, and then thinking about, like, physiologic implications of alcohol, full body, I think especially given how it's been marketed, as we were saying, as just, like, healthy and maybe good for you, I think people can it's so normalized, especially in your 20s, to drink a lot, and
Hmm.
because of that, I think it blinds people from asking questions when they might otherwise if they thought it wasn't that good for them. But how do you evaluate it? Because I know we work in sort of different settings at this point. I'm mostly
Hmm.
outpatient, you're inpatient with a little.
Yeah, I'm trying to think, like, what'll make me zero in on someone drinking. So usually I ask them if they drink, I'll ask how much. Like, I always start with frequency. And then I think therapeutically, I try to assess, like, can they have fun without alcohol? If they say they just kind of do it socially. And then I'll kind of be like, "Well, what's the most you'll drink in an evening?" And then,
Mhm,
like you said, I think I navigate through those 3 Cs that you're talking about,
mhm,
the, craving, consequences, and control.
mhm.
And I think I zero in on consequences probably the
Yeah,
most,
yeah.
because people can tell that the relationship struggles if they've been
Mhm,
drinking too much. So I kinda if they kind of express some indifference about it, I ask if other people have commented on it
mhm,
or if they have trouble getting up out of bed in the morning, things like that. So I think in general, the way I draw the line for a lot of things being pathologic is if it kind of stops you from living your life in the way that you
mhm.
want to. And so that's kind of what I start with. Like, okay, where is this causing like any amount of disorder for you?
Yeah.
And I think that's just a higher sensitivity. Like obviously if something's causing cravings are hard to control, it's probably gonna cause disorder, but
Mhm.
it's hard to suss that out. Like, I could still be functioning and not have a level disorder that's detectable by a psychiatrist or my friends, even just kinda be, like, white knuckling cravings throughout the day, but then
Right.
when you start to get to the consequences, then I can detect it easier.
Well, and I feel like it so depends on I th I think there's times, like, if you're meeting someone in a detox setting, obviously, that's a different conversation you're having than when you're meeting someone outpatient who kind of says offhandedly, like, "Yeah, I have, like, 4 beers with my friends, like, 4 nights of the week, but that's just, like, what we do," and, like, doesn't seem open to
Mhm,
talking about it, and I feel like when we think about this, like, related to our motivational interviewing episode, I feel like the style and how in depth we go with asking and inquiring about it is so dependent on how much it seems like the patient wants to explore it.
mhm,
Um, at least I try to outpatient. Sometimes that's less of an option if it's like it's the emergency department and someone's withdrawing and you, like, need to know it for detox treatment.
mhm. Yeah, it's hard because sometimes it's blatantly obvious that this drinking is causing them an issue. Like, you can read from their chart that they have multiple DUIs or
Mhm,
they've been admitted for detox. Like, that that's an objective measure of, like, disorder in this person's
yeah,
life. And
yeah,
then there's the person who's like, "Oh, yeah, once a month I have a glass of wine with dinner." Like, it's kind of the picture of drinking in moderation.
mhm,
So, I wonder if I could do a better job of asking about cravings, actually. Like,
hmm,
do you find yourself wanting to go get a beer after work or wanting to go do these things? And I think part of like a normal person is like, who doesn't after a hard day?
mhm,
And but also that if that's becoming kind of a habit, the fact that
mhm,
that this is now entering this reinforcement pattern,
mhm,
then that would put that person at more risk for developing an unhealthy relationship with alcohol. So I think I actually might incorporate like kind of my assessment of cravings a little bit more in my
mhm,
interviews.
mhm. Yeah, I think this also gets to the cultural norms and, like, I wonder sometimes how we collude with this in healthcare where there's such this especially in residency, there's such this, like, intensity, whether you want it to be there or not, like, just make it through things that are physically hard, like working for 24 hours, like, high stress, not having an outlet. I wonder sometimes if we miss seeing people because we're around people who are in these high stress jobs that need, like, a pressure valve, and so it's kind of normal in healthcare to rely on alcohol for coping sometimes.
Mhm,
And so I wonder sometimes if we, like, kind of miss things because we also are in a culture that's like, "Yeah, that happens." Like, that's who doesn't want a beer after work?
mhm. Yeah, it's an accepted and normalized coping skill.
Yeah.
Like, you can practice your box breathing or your controlled breathing, or you can go for a run, or you can have a beer. All
All
3 of those
3, or you
things
can
will
beer
take
mile,
away.
sorry.
Yeah, or you can have a shower beer. All 4 of those things will take away the unpleasant feeling.
Reminder that we are doctors, but we are in training and not your doctors. Uh, I guess one other thing I just wanna mention that I think in psychiatry we bypass sometimes is just thinking about taking really good care of people that you know or have talked enough about to be concerned in their agreement to, like, getting labs and things like that. I'm not gonna talk about inpatient and, like, emergency department. We're not gonna talk about, like, Wernicke and Korsakoff today, but I do think talking to people about their, like, organ health with alcohol, especially liver health, can be really important as part of the work we do even in psychiatry, given that we're the people who are often talking about these things with people. So just knowing like, checking with people on their kind of, like, health literacy on how alcohol impacts them, again, not bearing down on them so much that they feel shamed, but I found a lot of people, including myself before, like, the end of med school, we know that it's, like, bad for your liver to drink, but I think the understanding that the pattern of binge drinking where it's kind of, like, overwhelms the capacity to metabolize alcohol, that is particularly probably bad across the board in terms of what alcohol impacts organ and liver in particular. And then also that, like, there's not a healthy amount of alcohol to drink, which I don't think that has to mean no one should drink. Like, me personally, I say to my patients, like, there are many things that I do that I know are not, like, perfect for my health, but I want to be able to have the information of what they're doing, and I think as clinicians, it's our responsibility, if patients want to explore that at all, to be informed consumers so they
Mhm,
can know, and I'm thinking about, like, if someone has, like, normal LFTs, that's good, that's reassuring, but it's like alcohol is still impacting your liver if you're drinking in this particularly in the heavy pattern, not necessarily like a glass of wine a week to an extent that you I think people super need to worry about it, but, like, if they do have this kind of heavy normalized period, their liver's probably not loving it. They may be someone like the grandma who smoked a pack a day for her entire life and lived to 100. They may be that person, but also, like, I think sometimes, like, the understanding can be that it's either, like, all or nothing, like,
mhm.
you just drink, 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 and nothing happens, and then suddenly you get cirrhosis versus understanding the process, and I think as psychiatrists, we shouldn't shy away from that when we're talking about substance use with our patients so they can have the info.
I think the place where I give the most education is to someone who is actually probably in their mid-20s or early 30s, and they're like, "I
Mhm.
only drink on Saturday," but they get, like, blackout drunk. And so, 7 beers Saturday night may even be worse than 1 beer each weeknight throughout the week. And if you think about it, this you're still going through 5 drinks, 5 to 7 drinks in a week, but you're
Right.
just compressing them all into one evening where you're overwhelming your liver.
Yeah. Yeah.
So, from that person's perspective, they're like, "I only drank 4 times last month." But
Yeah.
each of those times was in a binge and a toxic amount and still meets criteria for disordered drinking.
Right. Right. Yeah. I mean, I think that's, like, the harmful drinking spectrum is, like, people drinking more than this amount per day or more than like, 4 drinks for women and 5 drinks for men in 2 hours, which, like, I hate to say it because I didn't know this in college, but, like, a Long Island iced tea is, like, 3.5 drinks, like, 1 Long
Mhm,
Island is that, so I yeah, I think that you're totally right, and the binge culture is so normalized that it's very easy to feel like it's fine.
mhm. Yeah, and to your point about there being, like, no quote, unquote, "healthy" amount of alcohol to drink, I think whenever I have to have that conversation with someone, I try to go, like, full philosophy mode.
Yes.
So I say, like, "Well, you know, life is really about how much time you have left and what you wanna do with it." And
Psychiatrists love talking about mortality, we
no,
do.
seriously,
I
like,
know, I
whether you
agree.
have 80 years left or 10 years left, like, do you want alcohol to be a part of those 80 years? Like, yes,
Right,
it could have some risk, but you know what else has risk of me dying? Like, driving to work. The
exactly.
fact that I woke up and exposed myself to like, there's probably no healthy amount of, sulfuric acid to be exposed to, yet when it rains, there's, like, acid rain in the city that I'm in, I'm gonna be exposed to it no matter what, but, like, to me, it's worth it going to work
Right,
because I wanna live a life where I can be, like, a productive and successful member and then have money that I can spend on my hobbies, so I'm like, "Okay, this is a risk I have to take." Like, I try to put it in perspective of, like, you are taking all these risks that are gonna have somewhat negative effects on you, and if you try to live in a bubble, it's not gonna be effective, so,
right.
yes, there is no healthy or beneficial amount of alcohol to drink, and also, that's okay, it's up to you to just decide how you wanna dial in that risk.
You know, the phrase, like, "pick your fighter," in my head, whenever I'm trying to make health decisions for myself, I'm just like, "Just pick your carcinogen." Like, pick and I say that only a little glibly as someone who has been impacted by someone with who got, a serious cancer very young in my family. Um, that they're like it sometimes it these the headlines that then pick up this, like, health information, like with alcohol, are so, like, panic inducing, and it makes more people click and read all these things,
Mhm.
but ultimately, what I wish is that people could have accurate information and then not have the fears of, like, illness and mortality, like, shoved down their throats with how it's written about is like, "If you ever look at a bottle of alcohol in your grocery store again,
You
you're a
will get
stupid,
cancer and
horrible
die,
person."
yeah.
Yeah, like,
And
but
and don't you know the purpose of life is to eliminate every carcinogen down to the point where you can live forever because you'll never die if you follow our advice.
right. Well, it's like a couple people had asked I had put in my story, on Instagram questions people had for this. And one of them was on talking about kind of this question of like, is there a healthy dose? And I think one of the things I think about as a psychiatrist when I have someone who's like, well, we're working on their, like, let's say they have social anxiety disorder. We're working on their social anxiety. They're on a good dose of an SSRI for it and it's helping. And we're doing like the right therapy for it to help them slowly have different skills and things like that. And every once in a while, they feel really uncomfortable, but it's important that they go to their friend's like wedding that's out of town. They don't know everyone
Mhm.
there. And they have 1 to 2 glasses of wine and they feel like it helps. Relationships and staying connected are also very important for health and stress management and mortality risk. And that's without even talking about quality of life.
Mhm.
Do I insist as their psychiatrist that all alcohol is poison? I don't personally.
Mhm.
And again, that's like a made up situation, but there's so much nuance in like what is a good long health span and quality of life.
Yeah, like, if I think about the things I'm doing that are gonna pose a risk to me, is isolating myself better, or is having a beer at the pub with my friends? Like, I guess I'm trying to think about 'em almost like vectors. Like, is
Mhm.
the positive vector of being close to my family, does that outweigh the single beer that I'm having? Because if I just
Right.
keep myself alone in my room and I isolate, and, like, ideally, you'd be able to socialize without needing to drink and other things, but some cultures, it's so intertwined. Like,
Yeah.
how do I tell the finance bro that, like, "Hey, man, like, maybe you just find a way to hang out with all of your bankers without drinking," and he's kinda like, Okay, dude." You know what I mean? Like, there's a lot of cultures where it's like, it's a part of the language to drink,
Yeah.
and
Yeah. I
I
mean,
remember even in
it's
med school.
literally in my religion. Like communion is wine.
Yeah.
And do I not partake in my religious things because it's a carcinogen?
Mhm.
You were saying you remember med school.
Oh, yeah, like, all of our, like, events where we would bond usually had something to do with alcohol and became like a thing. Like, there were Muslim students that were like, "Hey, can we have some events that aren't like
Mhm.
revolving around alcohol? Because it's hard for us to feel like we belong. Like, it's hard for us to integrate ourselves into this like community." And I was like, that makes a lot of sense, dude.
Yeah. Yeah.
All this stuff is based around drinking. Like, the
Right.
first bonding event we had in med school was the beer Olympics.
Yeah, and that's the other side of this coin. We're talking about, like, don't you maybe we don't have to go so far into panic mode, but I do think there's the other flip side of the norms and that everything is very, like, a lot of social events in your adulthood are very alcohol central, including in med school and healthcare.
hmm So, now we've kind of, I think, debriefed a little bit about the social landscape around alcohol. I think we can start to dive in more clinically. So, did you have anything that you wanted to say about medication assisted treatment? I know you left something in the run of show about that. And
Yeah,
then,
I mean, I think everyone in addiction and psychiatry thinks this, that it's like you don't say medication-assisted treatment in any other condition. Even treating depression, you're not like Zoloft, Zoloft mentioned, not sponsor,
Mhm.
Zoloft assisted depression treatment. You just say, like, treatment, and there's something inherently stigmatizing in that, in saying, like, MAT for substance use disorders. So, like, alcohol, like, we're gonna talk about medications, and it's like that and, like, opioid use, we talk about MAT treatment, and those are extremely regulated, especially for opioids, and there
Mhm.
is a lot of stigma, um, and
It's implied that you should be able to kick it on your own.
yeah, yeah. I don't see my friend giving themselves insulin who has type 1 diabetes, and I'm like, "There's another medication assistant." Like, "What?"
Yeah, like, you should be able to handle your diabetes independent of our help, but because you're such a moral failure, because you have no willpower, we'll give you medication-assisted insulin for your diabetes treatment.
It's like
Is
and then
kinda
the
like
person
the
that says
narrative.
that, like, the next weekend, they're, like, yelling at their kids, like, T-ball game. They're like, "Get" It's
Yeah,
like, "I have so much more willpower than you."
I know. Oh my gosh. So, yeah, I think that was kind of
Mhm,
that final point, which is even within psychiatry, where we already deal with stigma and have a lot of these ostracized conditions, substance use is its own black sheep.
mhm,
And I saw that. I was, just came off of a month in the, rehab center, and there's even just kind of this feeling around people that have relapsed several times. Like, you can
mhm.
feel it in the staff when, someone has checked back in for the 5th time to rehab, and there's kind of this hopelessness around it and also some judgment, even if
Mhm.
it's, like, subliminal,
Right.
and I was talking with my attendings about it, and they're like, "Yeah, it's really tough because relapse is the expectation. Like,
Mhm.
it's the exception if you don't relapse, but it's just a part of the cycle that people go through with addiction." And it's really hard because they have trouble helping patients kinda understand the balance between, like, here's where the disorder is and what we're trying to treat, and also here's where
Mhm.
my responsibility is.
Yeah.
Because some people, they push the needle too far and they say, "Oh, the disorder's not even real. It's all just willpower." Like, okay, that's
Mhm.
not the most accurate. But then people will be like, "I have no responsibility for anything I do because it's all the disorder." And then, just like people can do with other, like, somatic conditions, and that's also not accurate. It's something that you have responsibility for and
Mhm.
have to find that balance with your care team.
I think it's so frustrating. It's a very different approach than what we are taught in med school implicitly, the point of being in healthcare is, and I think that looking at your own helplessness to help someone else brings out really interesting and sometimes harmful reactions in us as clinicians because it's really uncomfortable to be helpless.
Mhm.
Um, and it's also very uncomfortable. Like, I think a lot of people who end up in medicine, it's like there's so many hoops you have to jump through that you kind of think like, I think it's easy to get a story like, I'm just like a hard worker and I'm all these things and people just need better choices. And like, certainly people in healthcare are hard workers. But I think to look at someone and see them struggling with addiction, you have to really tilt your worldview to be able to say, like, sometimes we don't have full choice over what we are doing. And I don't know, I think that's really hard for people to like let be true, that uncertainty.
Yeah. There was this story of a patient, who they came into the unit and they were going through detox, and they had been to rehab, like, 3 or 4 times, but, this time was different, and they were like, "Please send me to rehab, just give me one more chance. Like, I wanna stay, and I'm gonna turn it around this time," and a lot of people took investment in this patient, and like the attending, I think, even bought them shoes because
Mhm,
they didn't have shoes when they were getting discharged, and we,
mhm,
like, rallied together and got them clothes and all this stuff, and then it was, like, this heroic discharge to get them to the
mhm,
the rehab facility, and then they showed up and immediately got in a fight with the front desk and left,
mhm,
and then 3 weeks later, came back to the inpatient unit and we're back on substances and everything. We're like, "You gotta let me in," and the whole same story, and I think, like, I could, like, feel the burnout from, like,
mhm,
how much effort it was to do all these things for this person and then
mhm,
have it just completely fall apart, and I think, like, I really had to take a step back and say, like, how do I measure whether or not I'm doing a good job? Because if I
mm,
measured my success based on, like, this person getting better, I would just be, like, bashing my head against the wall. But then I could say, like, "Okay, I did all the things that I should do for this person," and
right,
then kind
right,
of stop it there, and I think that's where it's, like, extra frustrating, that helplessness, because we measure our success as healthcare providers based on our patients getting better,
right.
and psychiatry is such a hard specialty to do that in.
I had an addiction attending talk about this once, and it was, like, on kind of changing your measurement like you're saying, and it was, like, not the idea that just on a population level, there are people with the illnesses that we treat that some of them may die because of their illness, and or the illness may go on for their whole life, maybe not, but there'll be long periods of suffering. And if the goal is to get rid of the suffering or totally cure them at this point in history in psychiatry, w you're gonna not like this career very much because 'cause you're gonna have no wins. But if you look at it as, like, can I give this person a period of 6 months of sobriety where they get to, like, go to their daughter's wedding and be there and be present and make good memories with their family? Does that get to count as a win, both
Mhm,
for the patient and for you? Um And I feel like so much of that is so true in addiction and psych. It's like
mhm,
we have to change how we think about what good work is by us and by the
mhm.
patient.
And you might not know it, but you may plant a seed that doesn't grow for years. my voice just cracked, but, like, 5 years from now, they may think back on that conversation they had with you, and then that starts to change their behavior, but you never
Yeah,
saw that, and you may never know.
yeah,
Like,
yeah,
it really strikes me, now that I'm in longitudinal clinic, like, patients will tell me, like, "Hey, you told this to me, and it's been really sitting with me." It's
mhm.
never the things I expect.
It's never the thing you expect. You're like, "What?"
I'm like, "That sat with you?" I'm like, "Okay." Like, I think for one, I was just like I was like, "Yeah, bro, the half-life of, like, adrenaline's, like, 15 minutes, so, like, once you get anxious, like, your body's just reacting, you have to wait it out." Like, months later, they were like, I just
Bar.
realized I have to accept that I don't have control over it, and I was like, "That's what." I was just spitting facts about the half-life of adrenaline, but, like, hell yeah.
Hell yeah,
Like,
brother.
I'm glad it worked. So, and I think that's a good segue into now kind of talking a little bit about the physiology of alcohol. So, I wanted to kind of take a step back or step in to talk a little bit about how alcohol affects our brains and why it's so extra hard to kick this as a habit. So, first starting with the psychology of it. Oh, actually, when we come back after this break, after these messages, Preston's going to talk a little bit of science, if that's cool with you, Margaret, for all you science nerds.
We'll be right back.
We'll be right back. And we're
Welcome
back.
back.
Okay, Margaret, sit down. I'm going to tell you about the brain or what I found about the brain.
What?
She's actually already been seated, but I knew she was going to stand up for that. So,
Start clapping.
when you think about addiction, it's in a lot of ways a way to run towards a pleasant feeling and a way to run away from an unpleasant feeling. So the psychological terms are positive reinforcement. So reinforcement meaning like doing a behavior over again. I want to reinforce that behavior, but positively. So you're impelled towards a nice feeling. Or negative reinforcement, which is reinforcing the behavior, but taking away something that's good.
Mhm.
There's also positive punishment, which is introducing a bad feeling. And that's going to be important later when we talk about being punished for being sober and being rewarded for engaging in the misuse of the substance. So when we drink alcohol, what happens? You feel good,
Right.
right? So you get a sense of euphoria. And our understanding of why that happens is through one of our reward pathways with dopamine. So the nucleus accumbens, the ventral tegmental area, all that stuff that I love to talk about, that houses a lot of our dopamine. And when you actually look in rats and give them different substances, you can see about, I don't remember the exact moles, but I looked at relative concentrations of dopamine that was released. And
Mhm.
so on one end of the spectrum, you have methamphetamine, which let's say we'll put at a factor of about 15.
Mhm.
Cigarettes is about a factor of 1.1.
Mhm.
Alcohol is about 1.
Okay.
So both of them are about a tenth of what methamphetamine causes you to release, but they're kind of comparable to each
Mhm.
other. But alcohol, so if alcohol and cigarettes almost have similar amounts in small controlled doses, you
Mhm.
can get more of a euphoric feeling because you can just consume so much more alcohol,
Mhm.
but
Mhm.
it's not blasting the dopaminergic receptors the same way
Right.
methamphetamine is. So,
It's
point being, it feels good to drink.
do you think that there's also part of it where, like, I'm thinking of what alcohol is often paired with, that it's, like, not just the alcohol kind of dopaminergic transmission, it's often also, like, this is the social thing, this is the, like, dating thing, this is, like, you're
Mhm.
having good food with it, you're feeling belonging and
Yeah.
connection.
Yeah. So, everything else that your limbic system is gonna get excited about is associated with drinking, sex, food, socializing, things like that.
Mhm.
So, those all kind of get to hijack that same reward system and maybe, like, almost, like, classically conditioned with it.
Mhm.
You think about drinking and you think about all those other fun things you do. So,
Mhm.
that's the reward part of it, so we're impelled to do things. But then when you stop drinking, oh, and then so for negative reinforcement, sorry,
Yeah.
alcohol can take away unpleasant things.
Mhm.
So when you're drinking, what do you not feel?
Anxiety,
Yeah. So it
fear
takes
about
away pain.
ability
Takes
to
a
sing "Man, I Feel Like a Woman" at karaoke.
Yeah, all that social anxiety you have at the bar, that goes away too. Your inhibitions start to go away. You
Yep.
may get to take away the parts of yourself that you don't like,
Right.
the parts that you're hesitant about.
Right.
So that reinforces the idea that drinking can be helpful. If you're in a lot of pain, both
Mhm.
physical or emotional pain, alcohol can numb that.
Mhm.
So that's through this kind of next neurotransmitter, which is GABA. That's the one that everyone thinks about as the inhibitory neurotransmitter. So GABA is an ion channel, and it brings chloride into the cell. Chloride is a negatively charged ion, so it makes the neuron more negatively charged, which means it's harder to fire.
Mhm.
So you can think about it as just like dampening everything. It makes
Mhm.
everything more negative. Everything's harder to fire. And in our brain specifically, we actually have a huge density of GABAergic neurons in our cerebellum. So your cerebellum kind of sits at the occipital part, the base of your skull, and that controls a lot of coordination
Mhm.
and something we call metria. So your ability to kind of like organize and compute things as you're moving around. So if I would touch my nose to my finger or my finger to my
Mhm.
nose and then touch something else, I have to do a lot of calculations to make sure I know when my finger is going to stop and when it's going to like move around with each adjustment,
Mhm.
almost like making small adjustments on the joystick while you're aerial refueling two planes. So it
I,
actually,
totally understood that metaphor.
yeah, it's an Air Force metaphor,
I'm
but
like, "What?"
yeah, it's like trying to dock a spaceship,
Gotcha.
and you have to get all these inputs in really
Yeah.
fast. I think about it almost like a graphics card that's doing like millions of computations a second to generate the
Yeah, yeah.
picture.
Yeah, kind of
So
fine control, motor control.
yeah, it turns out that there are affective syndromes that can happen when the cerebellum is affected.
Hmm.
So these calculations are not only important for motor movements, but they also, a lot of them can have effects on our decision to execute something, or
Mhm.
impulsiveness,
Mhm.
and what's appropriate in conversation. So we find in patients that have strokes in their cerebellum, they can develop a
Mhm.
cerebellar affective syndrome and may speak out of turn or say inappropriate jokes or laugh or lose inhibitions.
Mhm.
So there's a lot more social and emotional implications that come through
Yeah.
what affects our cerebellum. Back in like the 2010s when I first learned about it in high school, cerebellum was like literally just balance and coordination. That's how we saw it.
You were learning about the cerebellum in high school?
Yeah, it was like my psychology class.
Oh,
My teacher
okay.
was like, "Think about Sarah Bellum, and she's a ballerina, and Sarah Bellum's always trying to bounce around and balance on one foot." I can still, like, picture
So
it.
shout out high
I'd be
school
like, "Sarah
teachers. Love
Bellum."
them.
Yeah. I'm like, "Oh, Sarah." Yeah, so back then, it was like the brain's modular,
Mhm.
This single Lego block in the back of your
Right.
head, that's balance and coordination, nothing else. But now we know, okay, wait, this computes a lot of different stuff and coordinates when and when not to execute an action, and that applies to talking and other
Right.
things. So it kind of makes sense that if you were to drink a lot of alcohol, that's gonna affect this thing. You're gonna lose your coordination. So we
Uh-huh.
know people stumble around, they slur their speech,
Uh-huh.
and then they lose their inhibition. So all that kinda makes sense for how it affects our
So
cerebellum.
alcohol makes you think you're a good dancer, but makes you worse at dancing.
It does.
You heard it here first. Yeah, do you think of it as different from other things that might impact GABA in terms of alcohol versus, like, impacting similar receptors? Also, we can cut this if you don't wanna talk about this, and we can
No,
move.
sure. So yeah, and that's a great segue into, like, how does alcohol actually affect GABA? So there's GABA A and GABA B receptors. We have a lot of, medications, things like benzodiazepines and barbiturates that specifically agonize the GABA A receptor, and they affect both the frequency and the channel opening duration.
Yeah.
What alcohol does is it affects presynaptic release of GABA, so you dump more GABA into every synapse, and you also affect postsynaptic augmentation of those receptors, and you can
Mhm.
displace those agonists. So alcohol kind of floods everything in a lot of different ways. And not to go too into the weeds, also because I don't understand this fully, is that we are affecting so much more than just like one single receptor and synapse. We're also affecting like across the way
Mhm.
and this really large volume of
Yeah.
drug is going into our body versus, something like Xanax, which is going to be more specific for that single receptor, which is probably
Mhm.
why you don't see all those effects from a benzodiazepine as you do with alcohol, but some similarities.
Mhm. Mhm. Gotcha.
There's another thing that I want to get into
Mhm.
that alcohol effects that also helps with its kind of numbing
Hmm.
property, which is not only does it make GABA stronger, so it reinforces this inhibiting neurotransmitter, it also attacks some of our exciting neurotransmitters. So, glutamate, the well known amino acid, it has a moonlighting job actually, and
You
it's a
just the
neurotransmitter.
this. I'm sorry. You're like, you're wearing a sweater vest with your glasses
I'm
and
like,
glutamate.
actually, yeah, it's not just in your proteins. guys, as a matter of fact, glutamate is exciting things in your brain as we speak. So, glutamate receptors, by and large, they're excitatory. They let calcium into
Mhm,
cells. Calcium is positively charged, so it's gonna make the cell more positive. It's gonna excite it. That's the easiest way you can think about it.
mhm,
And there's multiple different receptors for glutamate. So there's NMDA receptors, there's AMPA receptors, there's KIPA receptors.
mhm,
I don't want you to worry about what any of those do, but just that there are many different downstream effects,
mhm.
both at the transcription level and at the ion channel level that glutamate impact. And a lot of them have to do with exciting or turning on functions. Just about all of those are inhibited by alcohol.
Right. So we've got it increases our
It's
off and it
Yep, it's bolstering
decreases
our
the
off switch.
impact of the on.
Yep, and it weakens the on switch. So now when we're thinking about slurring your words, coming down from something, numbing everything, we're coming at it from 2 angles.
Mm,
I would
mhm,
think about it like we're it's winter right now, and I'm turning off the heater and I'm opening the window.
okay, gotcha, yeah, yeah,
So my house is gonna get cold really fast.
right. Then this is what we also think about when we're thinking about why detox is so dangerous and why recovery can be so hard
Exactly, and so
from
that's
both
that's
those
kinda
sides.
when the concept of positive punishment now comes in.
Mhm,
So we have to kinda get into the idea of what happens when you habituate yourself to alcohol
mhm,
over time. So if I'm if I'm taking a substance that increases my release of GABA, both at the
mhm.
pre and postsynaptic level, what do you think my body's gonna do with my basal amount of GABA?
It's gonna decrease it.
Yeah, it's gonna be like,
It's gonna say,
"Okay,
"You
guys,
got this, bud."
we have too much GABA going on. I don't know what's happening, but, like, we're getting way too much, so we're gonna kind of pump the brakes on our production of GABA."
I'm picturing the, SpongeBob episode where they, burn all the files in his brain, and that's just, what the GABA it's
Yeah,
like, "Burn
yeah,
all the
yeah, it's just
file
like,
burn all
"Okay,
the GABA."
gone." And then now for glutamate, despite all the glutamate that we're dumping out into the system, we're not getting enough signal through.
Mhm,
So
mhm,
now what does your body do? It's like, okay, well, screw it. We need to produce more glutamate.
mhm,
And so this is my analogy that I came up with today for how to describe alcohol withdrawal. So if if this is my fist,
Listeners, I'm hearing this for the first time.
this is my fist, and I want you to think that glutamate pushes my fist closer to my face, and GABA pushes my fist farther away from my face. Okay,
Mhm.
so I drink a bunch of alcohol, and it starts to push me further away. Oh, nice. But then my body's like, wait, we need to ramp it up a little bit. Let's push back towards the middle. And I'm like, no, I'm gonna drink more. Then it pushes it away. My body's like, okay, we're gonna make more glutamate, and it's gonna push towards it. And now I'm pressing really hard,
Huh?
because the system's tough, because I'm drinking like a pint a day.
Uh-huh.
I'm gonna drink even more, push it further this way. Okay, I'm doing this every day. And my body's like, oh, we're gonna correct. And then I'm like, wait, I should go get my appendix taken out and hang out in the hang out on the floor for 4 days so I won't drink it all, and bam! All that glutamate is no longer fighting against the alcohol to suppress it, and then it just goes into, like, disinhibited excitotoxic mode, and that's really the best way I think of alcohol withdrawal, which is this kind of imbalance between GABA and glutamate. That's how a lot of people
And
kind of
then
have phrased it to me.
doctors coming round on you, or you see people in the community, they go, "Why are you hitting yourself? Stop hitting yourself."
Yeah,
You're like,
exactly.
"I can't not hit myself." Well, we've solved alcoholism with that metaphor.
Yeah, we have I'm, like, sweating from it.
You're like, "I was pushing so hard." Um, yeah, I think that is really helpful, and that gets at the point of kind of, from a macro level for the body of whenever we're talking about to make this kind of clinical and concrete, whenever we're talking with our patients about alcohol, that if we start the alcohol conversation in any way, I think, and give any information that's like, this maybe you should consider cutting back, I think we always need to be having the conversation around the dangers of detox because
Mhm,
it can be so easy when you're short on time and trying to talk about a bunch of things to give someone the bad information, or the impacts of alcohol, and then they leave, but they don't know about detox. And if they're coming from drinking 4 or 5 beers a day or more, and then they just go cold turkey because you inspired them so much with your metaphor,
mhm.
then they can precipitate withdrawal, and withdrawal can be dangerous due to kind of changes in the excitatory that gets translated into
Yeah.
sympathetic activation.
And I think, like, my point for that third part of the, habit forming,
Mhm,
nature of the substance is that most people with alcohol use disorders that have withdrawals can start to symptom within 12 hours of stopping drinking. So now you have out kind of looking back at these reinforcements and
mhm,
punishments, you have positive reinforcement, this feeling of euphoria if you drink. It takes away the pain. And also now if I don't drink, a new unpleasant feeling is gonna be
mhm.
introduced.
Shows
So
positive punishment, right?
yeah, so this is an extremely hard substance to get away from, and I don't think there are many other substances, I think opiates is similar,
Mhm.
that behave similarly, because even something like methamphetamine, the level of positive punishment when you stop smoking meth isn't on the same level as it is with alcohol. When
What
people
makes you
come
say that?
because stop if you stop smoking meth and have extreme withdrawals, a lot of people will sleep and eat for
That's true.
several days at a time, which and they can be grumpy, they can be
I
frustrated.
say they can be pretty dysphoric.
Yeah, but that's not delirium tremens, I
Right.
guess.
The
Not
thing
to play, like, substance Olympics. Just think that, like, alcohol punishes you for not using it a lot more than other substances do.
one of the things that they would say on our detox unit was opioid withdrawal makes you alcohol withdrawal can kill you,
Opiate withdrawal makes you wanna
wanna
die.
die. Yeah. Like, it makes you wanna die. And so, yeah, no, I think from a danger perspective, yes, you're right. I think from a I guess one of the reasons I asked that is I don't know enough to push back on it to say, like, what is it like to live without, like, meth if you're,
Yeah.
like, day to day? Just I'm thinking of the opioids example because I don't know, once you get past those first 4 days with alcohol, it's still bad, but I feel like some of the other withdrawals are also awful. Um,
Mhm. Yeah, and I think, yeah, opiates is pretty terrible, so, I don't know.
yeah. There's some I was reading, I have, Kaplan and Sadek, comprehensive psychiatry, whatever, behemoth textbooks, and I was reading the alcohol and, like, substance use chapter, and also with this, the idea long term of recovery that this change doesn't end it isn't resolved after you have gotten through the detox period, right? It doesn't with
Mhm.
you're not like your brain neurobiologically is not recovered, quote unquote, from in a
Mhm.
balance of this kind of GABAergic, glutamatergic, like change it made up to like
Mhm.
a year of abstinence. So the change lasts that long. And so
Yeah.
preparing people thoughtfully for recovery, I think does mean giving them a more simplified, probably conversation than we're having right now, but like an understanding not to scare them away from recovery, but to help them not feel like if they're still struggling 2 months of without alcohol in and the cravings are really strong and the feeling distant from their life or feeling like they can't enjoy things almost like they're living behind like a glass wall is
Mhm.
like it can be helpful for people to understand that they're still in recovery, not in the not just in the way we say psychologically of like that the kind of urge to drink might always be there, but neurobiologically their brain has not fully kind of recalibrated, especially if they've been drinking heavily for a long time.
Yeah. It's incredibly tough to manage those expectations, but
Yeah.
if done properly, it can help them kind of stay the course. So, now that we've kind of gone through all the terrible ways that alcohol can get you under its spell, I think you had listed that you'd like to talk a little bit about how we treat it clinically now.
Yeah. So the 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 medication assisted whatever treatment. So clinically speaking, I think there's 2 agents I tend to use most often, and one I don't use as often, and I definitely also have a preference for naltrexone, I will say.
Mhm.
Um, so naltrexone is, I think, the primary thing that we use the most in terms of people coming off of detox, I mean, the first thing for detox is, like, if you're drinking regularly each day or you've experienced withdrawal symptoms, so, you know, hand shaking, heart racing, night sweats, chills, tremors, blood pressure changes, though you wouldn't know that probably if you're just a person walking around. First, we have to treat that, and the way we do it now is with benzodiazepines, but the way we used to do it, which I always get a kick out of this, is that they used to have beer or wine at the hospitals to do detox before benzos were invented, which is great.
Yeah, you could there's, like, an old beer order I saw at the VA the other day.
It's awesome.
Can you imagine, like, Q6 beer?
It's like, "I need a beer stat."
And also get one for my patient.
Yeah. You are funny today.
So, um, for those who aren't familiar with the pharmacology, what does naltrexone do again?
Yeah, so naltrexone is a mu opioid antagonist, and so one of the contraindications is if someone's also struggling with opioid use or they're on any
Mm,
opioid for, like, pain management, naltrexone, they're gonna have a bad time, you're gonna have a second withdrawal in your hands from the opioid, so it's contraindicated in that because it will kick them off the receptor for opioids, but
yeah,
it can
so
help.
it could precipitate an active withdrawal if you have a
Yes,
little bit of heroin in your system. Okay.
yes. Um, But for alcohol use, it can what we think happens is that it again, we've been talking about these kind of dopaminergic pathways and reward centers, is it can reduce cravings for alcohol and episodes of heavy drinking, um, through modulating the cravings probably, so, like, not having as
Yes.
strong of urges.
So there are mu receptors that mediate the release of dopamine.
Right.
So it's actually interesting. So with some opiates, you can get, hallucinations.
Mhm.
And so that's how I thought about it, like, okay, wait, so this mesolimbic pathway is mediated by the release of dopamine, which is kind of in some ways, the mu opioid receptor is a control knob for it.
Mhm.
So that kind of explains why you can feel euphoria. Also, you can have psychotic symptoms with extensive use of opiates in some people.
Mhm.
And then maybe blocking it doesn't allow you to get that same reward.
Right.
So then possibly that positive reinforcement isn't
It's
as
taken
strong.
away. Yeah. Yeah. Um, the one other thing we have to think about with naltrexone, you start it out as daily and you see if people can tolerate it. One issue with it is obviously liver disease, as we've mentioned, can co-occur with
So it's
alcohol use disorder.
metabolized in the liver.
It's metabolized in the liver, yeah.
Yeah.
And so you have to consider that. Although I think, like, we thoughtfully consider it depending on someone's liver function, depending on each clinical situation. But if they look
Mhm.
good on, like, LFTs generally, um, then utilizing it is fine, but still testing it for a couple days, people can have some GI side effects. And then you can do long acting. So Vivitrol,
Mm.
which is the injectable form that you can get once every month. People have actually have mixed feelings about not mixed feelings, different people like getting that medication in their recovery different ways. So some people like actually taking a pill each day to remind themselves of like kind of their promise to sobriety is what I've heard
Mm.
patients say it as. Some people are like, I forget the medication and then suddenly I'm craving and I forgot to take it and or I choose to not take it one day on purpose and I don't want to give future me that ability to choose. So
Mhm.
I think there's different kind of things that resonate more with people for the naltrexone, and that either of those is fine, although the long acting may be more effective on a population level. But I think if I have a patient who's like, "I do take it every day, and I notice it helps me more to be reminded of that promise," and there's
Mhm.
someone who shows up to appointments and has that insight over the long term, then I think that makes a lot of sense. But I also think
Yeah.
Vivitrol can be a great set and forget option.
Yeah. And I think it'd be cool if, we can start getting it to longer than a month or 3 months
Yeah.
or, because I think for paliperidone, we now have Invega Half-Yera, like
Mhm.
6 months.
The name is it makes me laugh.
Yeah, I always so it's like, if you could get a 6-month injection of naltrexone, like, that could be, like,
That would
really
be
helpful for
huge,
people that are
yeah.
going through these different levels of stress and,
Yeah,
something that could break their coping skills, may cause a
yeah,
relapse, but with the set and forget, like you said, it wouldn't happen.
yeah,
Okay, so naltrexone is one you're biased towards.
yeah.
What's another medication?
The next one is a acamprosate, which is the one that you take. uh, 3 times a day, and you it the reason I don't use it as much is just because I think most people don't do well with the 3 times a day medication.
Mhm.
Um,
Well, it's super annoying.
it is annoying. Some people, though,
So,
for the
when you wake
similar
up,
reason.
at lunch,
Yeah,
at dinner,
yeah. It's also dosed in a way that it
it's 666
yeah, 3 times
milligrams.
a day, and it's like, "What?" I think I don't know. That is always suspicious to me of, like, what was going on there that they were trying to, like, be like,
Yeah,
"Let's make it this devil number." Like, why? Why did you do that?
it's the satanic way to get off of alcohol.
I
Yeah.
devil-assisted treatment, sorry. Uh,
That
but I so, yeah, taking it 3 times a day, and then there's no long-acting form.
Mhm.
I think there's also some I don't know, I have different attendings say different things in terms of, like, efficacy levels. I think they both can be very effective, and then the one I do not tend to use is disulfiram, just because it's like, if people drink, if they drink, they're gonna have a very bad reaction because that's kind of the positive punishment?
Yep, positive punishment. So, same for the people who aren't familiar with the pharmacology of acamprosate. How does that one work?
I'm not remembering right now.
Okay, it's okay.
Sorry.
So, acamprosate mostly functions as an antagonist or a modulator of the glutamate receptor.
Right, okay.
So, we're affecting pleasure, and then I don't know exactly how changing these glutamate receptors can affect cravings, but
Mhm.
just kinda calling back to how we were thinking about the receptors that are affected by alcohol and how that informs these receptors that we're treating.
Right, right. Yeah.
Okay, and then disulfiram, how does that one work? This one
It
that punishes you?
yeah, it interrupts the alcohol, like, metabolism pathway, basically, so you end up with a
Mhm.
more you end up with more of the basically, like, metabolites that don't cause pleasant sensation and cause the negative, like, physical sensations, like, I think, like flushing, nausea,
Yeah.
things like that. And so
So
it's very unpleasant. It's like and you have to choose to take it also, right? So, like, if you're gonna drink, like, you just don't take it that day.
yeah, it's like you wake up every day and you're like, "Okay, time to hire the bodyguard to follow me around and punch me if I drink." And then one day you wake up and you're like, "You know what, man? Why don't you take a day off? I got it today. Don't worry, I
I
won't
got don't
drink."
I pinky promise.
And he's like, "Okay."
Yeah.
So, I I think that it'd be helpful if there was a long-acting version of disulfiram. It's like you hire him for 6-month installments.
But that can be dangerous. Like, the
Yeah,
disulfiram reaction can be not just unpleasant,
yeah,
but, like, dangerous and is why we clinically also don't use it. Because I don't know, sometimes people are like there are psychiatrists who are okay with their patients suffering and being like,
yeah,
"We're gonna have a consequence," but I think it's gotten to the point where there's been, like, cardiac impacts or, like, nausea, vomiting to so extreme that it's like,
yeah.
"Okay, wait, hold on."
So and also what you think about it is you have a positive punishment with not drinking, but we're trying to introduce a stronger positive punishment to drinking so that
Yeah,
that punishment's so much stronger than the other punishment that
right,
you'll just win. Like, it's just it's not the best way to modulate behavior in general to introduce more punishment
right,
rather
right,
than to
yeah.
take away reinforcement or something like that. So just kind of psychologically or operantly conditioning ourselves, it's
Mhm,
not the best approach, I think.
yeah,
If you're a trainee and you're listening, you're like, "Okay, what if I get this on my step test?" It, inhibits aldehyde or
nice.
acetaldehyde
Yeah, that is
dehydrogenase. The common, distractor is alcohol dehydrogenase, but that would mean that it doesn't break down alcohol at all, right?
mhm,
Because that's the one we're inhibiting. So if you don't inhibit alcohol dehydrogenase, you just have a buttload of alcohol and you would just die because you would never be able to metabolize your alcohol. So you get stuck with a bunch of acetaldehyde, and that's what makes you red and itchy and uncomfortable.
right,
And
right,
so we know, classically, like, the Asian glow
mhm.
is people from, Eastern Asian countries don't have as active acetaldehyde dehydrogenases, so they can have some of this disulfiram reaction almost
Yes, yes,
spontaneously just from drinking.
yeah, yeah.
Um,
And this is
and
also
then
part of why, like, what happens and why drinking is bad for the liver,
mhm.
even without these meds, is functionally a buildup of these pro-inflammatory met like, metabolite products as well as,
Can I say my formaldehyde fun fact?
I knew you were gonna bring up formaldehyde. I know you're so toxicology coded, and I was like, I can just feel him being like, "Do you know what that is?" Like, "Yes, you can. Go."
Okay, so, the reason why formaldehyde it binds to your optic nerve. It can cause you to go blind. It causes toxicity in your optic nerve, and formaldehyde is, one oxidation step from methanol, so a
Mhm,
single carbon. And so that's actually why a lot of shiners in, like, the Appalachian Mountains will go blind is because
mhm.
in the distilling process, you're supposed to
I knew you would
boil and
know this.
distill your moonshine like 8 times
Mhm.
because each time you get a little bit less methanol in the final product. But if you're a lazy shiner and you only distill it like 5 times, there's gonna be a high enough content of methanol in there that when your body drinks it, it's gonna convert the methanol into formaldehyde. It's gonna cause you to slowly go blind over time.
How did you learn
So
that?
me,
Yeah, where'd it come from?
I was a chemistry major, and also I stayed
How
at
did
an
I not know
Airbnb
this?
in, in, like, Western Appalachia, because so I did my med school in North Carolina, so we had some, like, rural rotations out there,
Yeah.
and I was, like, sitting with my Airbnb host, and she was just like, "Yeah, we used to shine here in these parts. My grandpappy used to rob banks on the Eastern Seaboard, then they took all the money out here, and then they run shine back and forth to Nashville." And I was like, "Nice. I won't go in the basement." But then she'd have stories about people going blind and shining, all this other stuff, so I was like, "Oh, this." I was like, "Wow, this connects with all the science that I learned before." It's
You were
fun.
like, "Life is so cool." You're like, "This is experiential learning."
I'm like, there's just so much life to be lived. So, yeah, so
Um,
that's why you should be wary of alcohol in a mason jar that someone from West Virginia gives you,
or
really.
some hipster dude in the city that has decided to start making his own because you know he's not
Absolutely.
doing that 8 times.
Yeah, he's probably not a judicious shiner, only by reputable, street alcohol.
Um, a couple, I think, other things we wanted to touch on, and I'm curious at your point in training, like, what do you think about this therapeutically? We've touched on the meds. We could go on about meds, and there's other ones that can be considered, like gabapentin can be helpful, topiramate can be helpful. I know you had mentioned GLP-1 emerging, but we've talked about the neurobiology and exposed
Yeah.
the things I need to brush up on before my boards. But what do you think of therapeutic approaches when someone comes to you and says, "I want to change this," and they're in your longitudinal, like, what do you think of things that'll help them cope without coping with alcohol in your
Mhm.
work with them in a
And
therapy?
you already said that the exact thing I was gonna focus on, which is coping.
Mhm,
So, I think our biggest challenge is gonna be to help this person find a way to cope
mhm,
without a substance in their life. For a lot of people, they end up replacing that substance. So, for a lot of people who are trying to kick alcohol, they end up taking up cigarettes,
mhm,
and they kind of come to this acknowledgement that's the lesser of the evils for them.
mhm,
Like we were saying earlier in the episode, pick your carcinogen. And they're like, "You know what? I'll take cigarettes over alcohol."
mhm, mhm,
And when people do that, I'm like, "I can't fault them for it."
mhm.
They're it's their way of stopping drinking,
Right.
and I think personally, when I think about ways that I cope and can
Mhm,
get better, it's reinforcing, community and activities for people, giving someone a regimen because you can get a lot of stability from your routine
yes, yeah,
that can kinda give you some inertia so that when things go sideways, you don't relapse as quickly as you would otherwise.
right.
So, one thing that I actually been talking about with some of my longitudinal patients is I just kind of sit down and say, like, "Okay, like, what do you do when you get home?" And sometimes it's like, I literally just watch TV and go to bed. I'm like, how easy would it be if, like, that was your routine to just kind of fall back into drinking? Like, it'd be
Mhm,
pretty easy because 'cause you're
mhm,
just trying to sit there and be like, "Okay, like, let me do deep breathing. Let me try to, like,
mhm,
draw or listen to music," which are,
mhm.
like, all the classic coping skills we hear,
Right,
but
and they're so abstracted from people because it's just
yeah,
like
yeah,
it's a word with
exactly.
no salient attachment to it.
So then I say, like, "Okay, like, where do you find community? Like, where do you hang out with people?"
Mhm,
And some of them will be like, "Oh, I don't do much." I'm like, "What do you like to do?" For one patient, they liked stargazing, and so I made this plan for them to, like, invite their neighbors over and do,
mhm,
like, stargazing sessions because they had this, like, super expensive telescope,
mhm,
and I was like, "Do you have, like, families in your neighborhood? People are interested
yeah,
in astronomy?" And he was like, "Yeah, I just never, like, thought about reaching out to them."
yeah,
So I'm like, "Okay, if we can kinda, like, get, like,
yeah,
once a week, you have this thing you're coming back to, and then all of a sudden you have a bad day and you're like, "I can't drink, like, I don't wanna drink." I like, "They're
Mhm.
coming over later. We're gonna do this thing together." There's, like, a sense of external accountability and also some new reprieve that comes from that.
Right. I mean, it makes me think of the, like, loneliness epidemic thing that we've talked about over the last 5 years, and that drinking and substance use went up during the first couple years of COVID,
Mhm,
and that, substance treatment, like with your patient, has to happen in community. Like, it has to happen with supports, with how hard this process is, that, like, having people who are kind and caring to you, but also need you to show up to the stargazing event, right? And
mhm,
will notice if you're drinking. Like, they'll notice it as much as hard as that is, but the being held accountable is, like, the core,
mhm.
I think, part
Yeah,
of this.
absolutely, and, we look at things like Alcoholics Anonymous.
Mhm.
I've seen people talk about how the 12-step program doesn't have evidence or isn't verified scientifically, which 12-step program aside, you have a organization where people are finding support with each other,
Right.
and, like, I've always encouraged that, like, you have an individual person who's, like, your what do they call it? Like, your mentor, I think?
Yeah. Or your
Um,
sponsor.
your sponsor, yeah, who's gonna support you and,
Mhm.
like, be that community for you, so, like, that's effective in and of itself, and all those are things I try to support.
The peer model in a lot of substance clinics now of, like, having peer coaches that are kind of removed from the AA model, and then there's, like, the smart recovery that are more based on, like, it's sort of similar where it's, like, a group that continually meets and, like, affirms a vision of life without alcohol and trying to stay in recovery, but it's less kind of it's not the language of AA, and it's more kind of
Mm,
psychology based.
and that's because AA is pretty religious, right?
Yeah, it's tried to get away from it, but yeah, the foundation is on there being a higher power and quite a lot of, kind of coming to sense of what you've done wrong and how you're powerless without God is the original language from the book by the creators of it. Um, a couple other things just therapy-wise that I think are important is sleep and alcohol. Obviously, alcohol impacts sleep. We won't get totally into that today. Um, but a lot of people use alcohol to help them sleep, and they are going to struggle with insomnia even if they didn't before, if they were drinking at night. And so, thinking about other medications to help with insomnia, thinking about sleep hygiene, but maybe more importantly, like CBTI approaches if you're doing therapy with them to help
Mhm,
them consolidate their sleep. And then the other kind of specific coping of, as we've talked about, we love exercise. Exercise in particular can be a very powerful um, way of coping, slash also baseline reducing distressing emotions and cravings in folks with addiction.
mhm,
And then I think mindfulness, even like I do mindfulness in session with a fair number of my patients, like we'll start or we'll end with like a 5-minute mindfulness part together. And I
can you do
think
mindfulness with me sometime?
yes, I can.
Live
I
on the
love leading
podcast?
mindfulness. I
That should
love
be
it.
our cold open next time,
Oh, we're
is
just gonna
Margaret leading
start
mindfulness.
start with
Yeah,
mindfulness? Yeah, I love it, and I love leading people through it. It's also just, like it's weird, but it's, like, a cool way of connecting with patients when you do it together in session, even over Zoom, 'cause you we both close our eyes, and I verbally lead us through it, but it's a moment of, like, we both are a little vulnerable in it, so I love it.
mhm,
Anyway, but all of those things and some other stuff as well in terms of stress management approaches and coping ahead plans and exactly what you talked about, of, like, creative ideas to find out what is, what is the structural part that alcohol's holding up in their life, and how do we think proactively about it's gonna be hard to do that part of your life without it. What might be able to put some things that maybe won't feel as good as alcohol and, like,
mhm,
openly it won't, but might replace it. So things like, I did make fun of big mocktail, but, like, having a ritual where you get to just relax, you can still have that without alcohol. So,
mhm,
all of those things I've found important with my patients, both at the beginning and then ongoing, honestly, with even if they're not, like, struggling with alcoholism, even just people who are like, "I feel like I started needing a drink after work 5 nights a week, and I'm not comfortable with that,"
mhm,
which gets us back to what we started with of, like, Is all alcohol bad? Can I drink? How do I change my relationship with it even if I don't think I have, like, a substance use problem?
Mhm. Well, I think that's a good place for us to kind of start to wrap up, and I feel like it's an apt conclusion. I was looking through some of the viewer submissions, and I think most of these are questions that we've kind of answered or at least touched on in the pod today. So someone asked, is there a way to enjoy alcohol without it being a part of your life? Is there a way to enjoy life without needing alcohol?
Mm,
Some questions on alcohol affecting sleep. So just if you're specifically concerned, like alcohol decreases the amount of REM you get. So and it also increases stress levels during sleep, so you're not gonna get as much deep sleep. So think about deep sleep as a way to heal your body, REM as a way to heal your mind. Really
mhm.
simple aphorism there. It's gonna decrease both of those. So like you may sleep more, but it's lower quality sleep.
There
My
was
Garmin actually tracks my sleep, and if I drink, it's like, "Your sleep score is an F for
You're
tonight." It
shit.
gets me a 25.
Get up,
Yeah.
we're going on a run. There was one other question where someone asked about we can't I can't speak to every psychiatric med with this, but I can speak to the specific question of SSRIs and alcohol and why it says, like, "Don't drink on them." Important concept with this is pharmacokinetic interactions and pharmacodynamic interactions. Pharmacokinetic being more based in metabolism and how our body, you know, processes and gets rid of and excretes drugs, and then pharmacodynamic being how kind of the impacts or side effects of drugs, and specifically in psychiatry, kind of collude together. For SSRIs specifically, ones like Zoloft or sertraline, Prozac, fluoxetine, classic SSRIs, I'm not speaking to SNRIs right now. It's more of a pharmacodynamic, interaction predominantly, meaning some SSRIs can make people tired, so can alcohol. People who are on SSRIs have anxiety. Alcohol, because of all the things we've talked about, can make it so that you're more anxious after you've been drinking. It can make
Oh,
it so that
anxiety,
your
right?
sleep is bad. Yeah. So it can worsen anxiety. So there's like kind of counterproductive
SSRIs
interactions
already
there.
can suppress REM too.
Yeah. Yeah. And then there are other like types of antidepressants like TCAs that can lower people's seizure threshold, can make you very tired. Alcohol also can have interactions in terms of people's seizure threshold, both when drinking and more frequently when in like withdrawal or it's leaving the system. And then MAOIs are always, we don't prescribe them as much anymore, but especially for systemic ones, so not the patch as much, but interactions with wine, very
Yeah, so
aged
that's a more
cheese.
kinetic
Those
interaction.
that is a kinetic interaction. Yeah, you're right.
Yeah.
Yes. Good
So
clarification.
things that have contain tyramine and
Yes.
can affect the
Yeah.
metabolism of the, like, catecholamines.
Right. Right. And there was other psychiatric meds, there's too many to list in terms of there is some overlap, with, um, like, if you're on any pain medications or other things can be in the same like, basically, like, SIP processing system. SSRIs generally aren't, but other kind of psychotropic meds can be, or pain like Tylenol is in the same,
Mhm.
enzymatic pathway to some extent, and so it's metabolism. Like, there was an interesting study I was reading preparing for this. I was talking about, like, the double hit of if you're drinking chronically and, like, then also take a bunch of Tylenol, and how people with alcohol use disorder who are heavy drinking are more likely to have more intense, even if they don't previously have, like, elevated AST or ALT, they can be more likely to have very severe outcomes from, like, a Tylenol overdose. So if you're someone with, like, depression and struggle with alcohol use, there's
Mm.
pharmacokinetic overlap there. So, point of that being is it's not it's not recommended because at odds with SSRIs, other meds, there's a different kind of situation on the direct med interactions from a metabolic perspective.
Mhm.
Sorry. I feel like that's like a I wanted to get that. I was like, "What
Yeah.
is going on there?"
Yeah, and it's like one of those where you have to add a million caveats to it
Yeah.
because, like, this is not medical advice, and we don't know about your specific
Yeah.
situation. Because I think when people are like, "Well, what's the deal with drinking on them?" I almost feel like there's an implied, like, "Can I actually drink on my SSRI?" Like, is that what you're asking? We can never answer
Right.
that.
Right.
Um, the last thing that I wanna leave us on is GLP-1s, which we
Mhm.
didn't talk about. So,
Mhm.
GLP-1s affect leptin and ghrelin levels, and so if you're not sure, glucagon-like peptide is exactly what it sounds like. It's something that mediates our, feeling of satiety. So when, you release a bunch of glucagon, you're, like, full. So it kinda tricks your body into feeling full. And so a lot of people, they feel full all the time because they take this medication, so they eat less. Their metabolism kinda slows down, they're not absorbing as much food, so they lose weight. That's kinda how we understand how GLPs work. But it turns out that in your cerebellum, there's a lot of leptin and ghrelin receptors that can mediate your cravings. So some of the thought is that in regions of our brain that we know affect inhibition and our relationship with alcohol, there may be different sources of those cravings. So maybe GLP-1s could have some effect on that. That's all we know so far. I think there's currently a couple trials for it.
Hmm.
We're kind of doing this thing that we do with a lot of drugs where we're just like, let's try it on
What if it
everything
works
and
for
see if it works.
everything?
Yeah, no, seriously. Like we're doing
Yeah.
that with TMS right now too. So
We do with
I think
naltrexone
we're
a little bit
trying
too.
smoking cessation and GLP-1s as well. I
Mhm.
think we're trying ADHD with GLP-1s.
Hmm.
Like it's across the board. So we'll see. As a society, we'll see what sticks and what doesn't.
Yeah.
But
Yeah.
that's kind of the theory, at least for alcohol
Yeah.
use disorder.
Yeah. I think, final words on this, I would say if you have questions about your relationship with alcohol, talk to a clinician, talk to your therapist, talk about it with your friends. I think more people struggle with this than we realize in terms of just being uncomfortable with their relationship with alcohol, and know that there are a lot of ways to get help with it, and it doesn't always have to feel like this. Um,
Mhm.
and that the information is morally neutral, I think, that if you struggle with this, a lot of people struggle with it, and it's something that there's a lot of shame and stigma around, but I think too much so, and it prevents people from being able to get help and get better.
Well, thank you all so much for listening. Please let us know how the show was. If you want us to answer different questions or write in other things, we're always happy to hear it. You can message us directly on our account. So I'm at It's Presro and she's at Bad Art Every Day. Or you can find the IG and TikTok at Human Content Pods, or you can contact the team directly at howtobepatientpod.com. Special thank you to Channeling Van Gogh. This is our first shout out in the post section. He said, or he or she said, I'm a young attending physician in a different field / subspecialty, but very much enjoy this podcast. It resonates both as a person and a physician on many levels. Well done and thanks. I can't wait to see and hear how it evolves. Wow, that sounds super clinical, but here we are. That's okay. I always sound super clinical when I say things, and I'm trying to be like fun and spontaneous. It's like the whole point of our podcast. So, anyways, Channeling Van Gogh, you're doing great. This gave me the fuel I need to make it through a couple more podcast episodes.
Okay, now my presence definitely.
Oh, also Margaret, she's why I get up in the morning.
That's true.
Saved it. Full episodes can be found on my YouTube channel each week at It's Presro. We'll also do like kind of teaser and fun trailers from the videos too. We make shorts because we're hip. Thank you again for listening. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, her, Margaret Duncan, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Portizo. Our music is by Omer Benzvi. To learn about our program disclaimer and ethics policy, submission verification and licensing terms, and our HIPAA release terms, go to our website, howtobepatientpod.com, or reach out to us at howtobepatient@human-content.com with any questions or concerns. How to Be Patient is a human content production. Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just gonna pet Lilac, and then I'm gonna go dance in the background.